Good evening, everybody, and welcome to tonight's Open Hand Therapy Initiative webinar. The webinar for July, we're halfway through the year. This webinar is brought to you in association with the University of the Witwatersrand in Johannesburg, as well as the South African Society of Hand Therapists. My name is Kirsty and I will be hosting this webinar this evening, but we have the pleasure of having Sarah Mee with us this evening to present on managing the metacarpal from fracture to function. And after her presentation, there will be a time for questions and discussion, but please feel very free to post your questions in the chat as we progress through the webinar this evening. If you have any questions about the Open Hand Therapy Initiative, please feel free to contact us. But without further ado, I would now like to introduce our speaker for this evening, Sarah Mee. And Sarah Mee is a highly specialized hand therapist. She has a master's degree in hand therapy and a postgraduate diploma in biomechanics, but probably more impactful 3 decades of hand therapy experience. She is currently a consultant hand therapist at Chelsea and Westminster Hospital in London. She teaches extensively, regularly presents at conferences, and has published peer review articles and a number of book chapters. She is very involved also in supporting hand therapy development in a number of settings, including in Malawi. And so she is familiar with working in a resource constrained setting. Sarah, it is a great honor to have you join us this evening. Thank you for your time and generosity, and I'll hand over to you.
Great. Thank you very much indeed. What I'm hoping to spend some time on today is metacarpal fractures, obviously one of the most common fractures that we see. So thinking really more about how do we clinically reason? So rather than giving recipes for how we treat each type of fracture, looking at anatomy, looking at healing factors, looking at potential complications, and then just some clinical reasoning for protection, for exercises, for function, etc. So ways for us to think about metacarpal fractures, and hopefully that's useful. So I thought I'd just give you all a couple of minutes just to have a look at this fracture. So intermedullary KWAS for a fractured fifth metacarpal. And just thinking about what would you do if you saw this kind of fracture. I like to try and think you can see a sort of list of things that are like a checklist of, what's the fracture type? What's the fixation type? So again, we'll look a bit at stability of different fixations. What stage of healing are they at? So how acute, how quickly are you able to see them? Particularly deforming forces. And we're going to spend a little bit of time looking at which muscles might pull fractures out of place. And then really for us as therapists, our biggest job really is to balance the stability of the fracture with how much we can move them. So we know for everything we do in hand therapy, early movement gets us better results, certainly better, quicker return to function, work, etc. But we have to think, how do we keep our fractures safe at the same time as getting that movement? Obviously with surgery, one of the problems is the risk of scar. Well, there will be scar and the risk of those tendons tethering. And then obviously the patient. So that may well be another factor which we need to take into consideration. So we're going to look at each of those aspects and look at some cases as well as we go along. So we know there are quite a lot of different types of metacarpal fractures, those that are head fractures. Hopefully you can see my cursors. So around the head, quite common in professional boxers we see. But those involving intra-articular, so joint involvement. Neck fractures then very common, particularly of the fifth metacarpal, so some of our most common from people punching another person or an object. Shaft fractures, again, really quite variable, but often produced by a direct blow, by longitudinal compression, something hard hitting the hand, or something that twists the hand. And so we get a number of different fracture types, maybe transverse, oblique, spiral, comminuted, and that means we have to think a little bit more around how we manage those. And then base fractures. The second to the fourth metacarpals, base fractures are relatively stable. We know they're held well in place at the carpometacarpal joints. The fifth metacarpal fracture at the base for us is quite common, and obviously often the result of really quite a strong force from the top of the hand. So again, hitting something hard or a direct blow. And they all have slight differences in how we think about them and how we're going to manage them. One of the good things about metacarpal fractures is the anatomy that sits around it, which makes them in many ways relatively stable fractures in comparison to those of the fingers. We've got this deep transverse metacarpal ligament, which wraps around the head of each of the metacarpals and then holds them between. So that has some flexibility to allow us to change the arches of the hand and the movement of the hand, but it does hold that distal end of the metacarpals nice and firmly in place. On the volar surface, we've got the natatory ligament, so part of the fascia, which again gives quite good support at the metacarpal head level. So that makes a lot of those fractures nice and stable. Along the shaft, we have our interossei, and we know they originate off the metacarpals. So it's something to be aware of in that they can be damaged as part of the fracture. They can get quite tight if the hand is not held in the right sort of position or exercised in the right way. But again, they provide stability because those muscle fibers are holding along the shaft of the metacarpal. The lumbricals are not attached onto the metacarpals, but they do give us volar stability, so support in the palm of the hand. The intrinsics, as we look at the hand moving, and we know, if you can see my hand on the picture, that they work very strongly in this intrinsic plus position. So MCP joint flexion, IP joint extension, but they lie on the palm side, the volar side of the MCP joint as we come down into a flexion position. So again, another point of stability. And for the little finger, abductor digiti minimi is the muscle that allows us to abduct our little finger over to the side. But it's another intrinsic muscle that gives quite good support along the shaft, the neck, and the head of the fifth metacarpal. So lots of things that help us and allow us to move these fractures early. But there are deforming forces. So there are situations where muscles can pull things out of place. The mechanism of injury of a lot of metacarpal fractures is either in a fist or at least in a closed hand, whether someone's falling onto it or having something impact a ball, for example, hitting it. And with quite a lot of them, there is this change. So I'm just going to move my screen a little. You get this dorsal apex fracture. And it's pulled into this position by those interossei and lumbricals, which are traveling across the hand, but lie volar. So they're lying in that volar aspect of the MCP joint. So they drag the distal fragment into a more flexed position, into a volar position. Depending on the type of fracture, will depend on how much they pull across. And you can see again here for a neck fracture at the bottom, partly that's a mechanism of injury. So if you have a closed hand as you hit something, it's going to push the head of the metacarpal forwards. But also those volar acting, the palm acting muscles are going to drag the distal fragment forwards. The other thing that happens is that your extensor muscles are lying on the dorsal surface and they have a tendency to drag the more proximal fragment a bit dorsal. So you can end up with that dorsal apex fracture, and that's quite common in a lot of these fractures. So the other thing we'll have a little look at, which you can see here, is when your hand is in a more extended position, which it often is from A&E or when they're put in a cast, You can see the base of the proximal phalanx sits on the dorsal surface of the head of the metacarpal. Now that produces that volar force. So that's pushing the head of the metacarpal into a further volar. And we're going to look at ways of managing that slightly differently as we go through. So that's one of the sort of key issues really with managing that sort of deforming force. When you have this angulation of the neck, often with an impact, but we know that angulation of the fourth and fifth metacarpal, such as this X-ray in the top right, actually it has very little impact on functional results because the base, the fourth and fifth carpometacarpal joints have a lot of movement. They can compensate. And so there's a lot of evidence to say that even up to 60 or 70 degrees of volar angulation of the head doesn't make a difference. So they don't need to go to surgery, and they don't necessarily need to have anything other than splinting and exercises to manage them. Often there's just a cosmetic impact, so they lose that knuckle, the look of the knuckle on the back. And there again, evidence I've put at the bottom, some more recent evidence of early motion in a safe position does not increase that angulation. But the second and third metacarpals, such as this one on the bottom right, that because we know the second and third carpometacarpal joints are fixed. They have no movement themselves. So there's no compensation. So you may well find then that actually angulation around the neck or head of the second or third metacarpals does need consideration of surgery, or may go on to get a less good result because of that inability of the carpometacarpal joint to make a difference. If we think about deforming forces for shortening of the metacarpals, which obviously we need to be careful of, the intrinsic muscles, as we talked, and the extrinsics as well, so both the flexors and the extensors, are going to pull on that distal fragment, such as here. So they're going to drag it, depending on the shape of the fracture, more proximally. And you can see here that it's shortening. If you follow the line, here we're at the third metacarpal, you drop not quite a centimetre, and then you've got a much bigger drop down to that little finger. So it's shortened. So thinking about deforming forces, and we'll talk a bit about how we splint, is those extensors and flexors in the digit, but also particularly for those base fractures. So on the bottom right picture, abductor pollicis longus is a really serious deforming force for base fractures of the first metacarpal. And obviously for the base of the fifth, your extensor carpi ulnaris is inserted into the base. Flexor carpi ulnaris as well, but that has less of a deforming force than the extensor. Flexor carpi radialis can drag on the base of the second and third metacarpals, but slightly less so. So again, just muscles for us to be aware of when we're thinking about splinting. Should we include the wrist? Should we not include the wrist? May depend on which muscles become a deforming force, and we would then want to stop them in that first few weeks from causing problems. We also know that with shortening, one of the problems with a shortened bone is a lag. So if you have a shorter bone, the extensors and the flexors now are baggy. They're long in comparison to the length of the bone. So you can get a lag at either the MCP joint or actually quite commonly at the PIP. And one of the things for us, again, in therapy is that 2 millimeters of metacarpal shortening can be up to a 7-degree extensor lag. So 2 millimeters is nothing. So if you have, 10 millimeters, 8 millimeters of shortening, you can have a 20-degree extensor lag. So being very aware of what is that relative length. Flexors, because they're very powerful, are able to compensate for shortening, but extensors much less so. So something else we'll look at when we think about rehabilitation. In rotation is the last one really to think about deforming forces. Obviously, if you have rotation, the problem is that the finger beyond that is going to rotate. It's mainly an intrinsic muscle problem. It has the most functional impact. So obviously, if you have a finger that is twisted across the hand, that is going to make gripping and function much more difficult. And it's a strong clinical indication for surgery. So most patients that have a rotation that's obvious on X-ray, or certainly is obvious clinically, as you look at them, they will go on to some sort of metal work in order to relocate that rotation. And just to sort of prove the point, a malrotation of 5 degrees in the metacarpal shaft can produce up to 1.5 centimeters of overlap of that finger inflection. So a relatively small amount of rotation can have a really big impact. Also for us to think about as therapists is healing. So we know there are two pathways. There's primary bone healing, and that occurs when the fracture is fixed. So this is when you have plates, screws that produce compression. So they pull the edges together and they compress the fracture site, and that gives us absolute stability. It allows growth of cells across from one side to the other with no gap. And those are ones, again, doesn't produce callus, but you need that compression in order for the healing to happen. Secondary bone healing is what we see very commonly with metacarpal fractures, where there may just be a closed reduction, so no metal work, or just K-wires, external fixators, or just splinting. And all of those are relative stability. So they're not strong enough for us to move them freely, but they need some movement in order to encourage healing. So if you immobilize these fractures, the healing slows down, because that little bit of movement you get at the fracture site, you get just micro movement, stimulates the healing cells. That forms a soft callus and then a harder callus, and that bridges the gap, and that enables the bone to heal. So we'll look again a little bit at what does that mean for us as therapists. So metacarpal heal really easily. They're very rare to go on to a non-union. The metacarpal head, neck, and the base are largely cancellous bone. They don't have a lot of cortical bone. So that means they heal more quickly because it's spongy bone anyway. So generally those fractures will heal within 3 to 4 weeks, and you can start moving them quite freely from that stage and beginning to load them. So beginning to get the bone to strengthen a little bit more. The shaft is more cortical. So you can see here the white on the X-ray, that's cortex, that denser bone. So that takes longer to heal because it's thicker. So those shaft fractures may well take 5 or 7 weeks. So there's a couple of extra weeks you may need to protect them from function or from loading them too much, particularly if they were going to be, going back to play sport or heavy lifting or go back to work. Blood supply is very good in the metacarpals, so very rarely, as I say, do they go on to non-union. And I think just to show you, here you can see this is a fracture on this side. These have been lag screwed. This is absolute stability with compression. We're going to move them early. That's going to heal with primary healing. This one with just splinting is going to heal with secondary healing. But again, they both need movement to get the best result. We think about union, and for us, radiological union, so union that you will see on an X-ray, this is, sorry, a distal radius fractured, because this is just what I had to show. You can see the fracture site here at 3 weeks. But in order to get to a point where on X-ray it's consolidated, it takes 6 months. So we don't use X-rays to tell us about healing. We can assess it. So we can use clinical union. And once we know that that clinical healing, that bone is beginning to stick, we can grade them into the next stage of our therapy. And the way to do that is to palpate. So to feel across the fracture site. You're not going to break it again. We're not going to cause problems. You do it gently so that you're assessing, first of all, is there any crepitus? So can you feel a grinding in the bone? Can you feel the bone moving a little bit, or a springy feel? The biggest thing is there pain or tenderness? So when you're palpating, does it hurt? And if it does, it's not healed enough, and you may need to slow down a little bit what you're doing. If there's no pain when you're palpating, then you want to tap it. So you want to then percuss it. So tap it just with your finger. So you're vibrating the fracture. If there's no pain, the fracture is healed. And for many metacarpal fractures, you're going to be getting that clinical union around 3 to 4 weeks. So we don't want to over support them, over protect them. So assess and move your patients on as you can. One of the things to assess, obviously, is rotation. Sometimes people who, have either had surgery or have not, and by the time we see them, you can see a level of angulation. The biggest thing is to look to see each finger should point towards the scaphoid, so should point towards this slightly radial aspect of the wrist. You can see from the bottom picture that index finger should be facing here towards the scaphoid where my cursor is. So that's obviously an angulation of the metacarpal with quite a lot of change in the finger. Once the bone's healed, we can't change that as a therapist. But in the early stages, we can use buddy strapping, and we'll talk about that in a minute, in order to help that rotation. So in the first few weeks, we can help to improve that just with the splinting that we do. So assess them just looking at swelling, range of motion, and obviously any rotation or extensor lag. We may need to change what we're doing therapy-wise. I'm not going to spend a lot of time on surgery. We're looking at a few x-rays with surgery, but certainly for us here in the UK, 90% of the metacarpal fractures that we see do not have surgery. So the vast majority are managed by us with splints or casts, and we treat them. So very, very few go on to surgery. A lot of them will heal with maybe a small deformity or maybe a little bump, one of those little dorsal bumps on the back of the hand. They may have a change in the look. So when they hold their hand, there may be a change, in the cosmetics of the MCP joint. But if it's good, if it functions well, and the hand has good strength and the hand has a good range of motion, that surgery may well not offer anything better than that. The risks of surgery are scarring, pain, change in motion, stiffness, etc. Only rotation or marked angulation need to go on to surgery. And, open reduction, internal fixation with the wires we looked at in that first slide, plates, screws, do allow early motion, but a lot of scar. So it makes our jobs quite difficult getting those patients to move. K-wires on a closed injury are good, but again, you may feel if the K-wires are higher up towards the MCP joint, you can't get very good flexion in the first few weeks because the wires are skewering through the soft tissue. But the wires should come out at 3 weeks. So K-wires should be removed from pretty much every metacarpal fracture by 3 weeks because they heal quickly. And if you get them out early at 3 weeks, they start to gain range of motion really quite quickly after that. Obviously, we have lots of complications which we need to be very aware of. Post-operative infection, delayed healing, nerve injury, oedema, pain, scarring, tethering of tendons, reduced range of motion, extensor lag, reduced function, many. And you can see here, this was a base first metacarpal fracture, which was plated. And you can see again, just swollen, thick scar and that's a thumb that's really struggling to get moving. Non-operative pain, maybe a lag. Intrinsic tightness we'll have a little look at, tethering, reduced range of motion, reduced function, and rarely malunion or non-union. So non-operative is going to give us fewer problems on the whole than operative. So what do we do? So the rest of this is now really, how do we think about managing these patients? Protection, decreasing edema, decreasing pain, regaining range of motion, maintain tendon glide, managing scar, regaining function, and passive movement, which again, we're going to look at all of these in turn. You can see here on the slide, we're looking at flexor digitorum profundus, so FDP flexion, and also an FDS flexion with a flat fist, so getting the flexor tendons gliding separately from each other and not only coming down into a full fist. So I put this in really as a summary. We looked at this right at the beginning, but just for us as therapists to think about the mechanism of injury, the healing, the fracture, deforming forces, stability, active movement, tendon tethering, patient requirements for function. So that's my sort of checklist of what I'm looking at with my patients. So splinting obviously is one of the big things for us. And really for us is to think when and why. So should they be forearm based? Should they be hand based? Should they include the MCP joints? Should they include the IP joints? Where to stop on the volar surface? And I put up a couple of fractures for us to have a look at. So this neck fracture, it's very distal. So do we need to include the wrist? No, it's not involving the CMC joint. It's not involving any wrist movement. It can definitely be hand-based, but it's very close to the MCP joint. And they're patients that often end up struggling to get that MCP joint flexion. So having a little hood that pulls the fingers down, and I'll show you some pictures in a minute to maintain some MCP joint flexion, will improve that movement early. Conversely, if we look at this X-ray at the bottom, this is a fracture dislocation of the fourth and fifth carpometacarpal joints and metacarpals. Do we need to include the wrist? Yes, we do, because obviously that fracture very much involved in wrist movement. Do we need to include the MCP joints? It's a long way away. It's going to be stable with just the hand supported. If the patient can flex well early on, leave them free. Leave them so that they're moving around. Maybe a buddy, just to give them a little bit of support. But if your patient has a lot of swelling, a lot of pain, and they're really struggling to get that MCP joint flexion, despite the fact that the fracture is down at the base, don't leave them sitting in that hyperextended position, because we know within 1 or 2 weeks already they will struggle. So you may want to put a little hood onto your splint to hold them down, but maybe only for a week until they're moving better. And then you cut that off and let them move more freely. So thinking about at what point are you going to splint? When can you cut a splint down? For something like this, which has a plate and screws, this is very stable. We know it's going to get really stuck, so that extensor tendons are going to tether onto where the surgery site is. Do we need to give that a lot of protection? No. We want them to use that hand for light activities without splinting. But we don't really want them to go out on the bus or the train or into a crowd with no protection. So maybe a little resting splint or a little clamp, which we'll have a look at in a sec, that will just give them that little bit of protection when they need it. If they have young children at home, they may need something on the fracture more of the day in order to protect them. but they don't need it very much for light function or for their exercises because we have a stable fracture. So I put a summary in of my sort of thoughts around splinting. We're largely thinking about MCP joint flexion about 60 degrees or more. This puts the collateral ligaments on stretch. It gives good stability. But if somebody can achieve it already without pain, you might not need to splint it. For a base, you need the wrist included. If it's a distal head or neck fracture, leave the wrist free. If it's a shaft fracture, you have to work that out with the fracture and the patient, because you may need the wrist and the MCP, and you may be able to cut one down a bit sooner. So those are ones that we can't really have much of a recipe for those. If they're unstable, fourth and fifth metacarpals or carpo-metacarpal joints, we need to include the hand for flexion extension. And also because we don't want those fingers, as soon as you make a really tight fist, you can see on my hand here, you add a lot of rotation to the base. So you want something that's going to hold that metacarpal nice and flat so it doesn't allow for that over rotation in the first few weeks. So thinking about the normal arches, the normal movement of the metacarpals. Tend to include the adjoining finger. IP joints included only if you have a lot of swelling, a lot of pain, and very poor extension. Just ideally you want them to move more, but you may need to for 1 week or 2 weeks until they're moving better, but then cut the splint down. I put in just some of my patterns, so these were just for you to have. You've got the handouts. So if you're just doing what we call an ulnar gutter, so this piece wraps over the dorsal surface, and that would be for a fourth or fifth head or neck fracture. This is a radial gutter with a hole for the thumb, and again I'll show you those in a sec. And I put in just a little clamp, so those are ones just to support the metacarpal, and then one for the first metacarpal. So just in case, having some new patterns or different patterns are fun for you to see. So we've talked a bit about MCP joint flexion, and one of the really important things, as we said, is this in an extended position. The proximal phalanx pushes on the dorsal part of that fracture, and that will push the head further out of position. If you bring it round to here, you can see now that base of the proximal phalanx is sitting underneath the head, and it's like having something pressing up onto the forehead of some, and it just holds it back into alignment. We know it also supports the collateral ligaments much better, and it keeps them on stretch. So we're always aiming, whether someone's in a cast or a splint, MCP joint flexion for that first few weeks. The longer they sit in extension, the harder it's going to be for us to get MCP joint flexion back. The collateral ligaments and the dorsal capsule get very tight. However, we know an intrinsic tightness, so we stretch the intrinsics in an intrinsic minus position. If we're sitting them in an intrinsic plus position, they can get a bit short over the first few weeks. So once the fracture's better, you want to add in your intrinsic minus active or passive. And I've suggested here active intrinsic minus position from 3 to 4 weeks and passive maybe from 4 to 6. So don't forget to check whether those intrinsics are a bit tight. That's the only downside, the only potential complications from holding them in an MCP joint flexion position after the injury. And that's just showing a passive stretch. So this type of very simple neck fracture, very little angulation. You can see just a little bit of volar angulation here. In many cases, if it's not too painful and sore, you could just have a buddy strap. So you could just put a buddy strap between the little and ring fingers and let them gently move. You could put a little clamp if there's pain and swelling. And we'll look at some ideas in a minute. So keep it simple. This is a simple, very stable fracture, very unlikely to fall out of place. not a lot of deforming forces. You can see from here there's not a lot of swelling around the hand, so manage them simply. If they're angulated, edematous, painful, or post-surgery, these wires here are relatively stable. They're not very strong. So ideally, if you can, you want to see them early. So the earlier you can get your patients, the sooner you can get them moving. You may include for this fracture, the wrist, MCP joints in a little bit of flexion, fingers free to move so that you're not letting them get too stiff. But make sure that you cut it down. So once it's started to heal, make your splint smaller so that you're not letting them get too stiff. Listen to the pain, look at the swelling, look at the movement, listen to your patient. And these are just some ideas. So this is a forearm base for base of fifth metacarpal. So this is the ulnar side. You can see a little hood at about 50, 60 degrees, allowing full IPJ flexion and extension, and flexion all the way down to the hood. This is a radial gutter, which was that pattern I showed you earlier with a hole for the thumb. And then wrapping, you can see here, wrapping around, holding those MCP joints in slight flexion, but leaving the fingers free. So allowing them to flex into a safe position and allowing light function in the splint. Again, if you're supporting a metacarpal fracture that's stable, let them function within their pain limits and within what your splint can allow. So they're not being immobilized in any way. They heal better and quicker if they're doing a little bit of movement and they get a little bit of compression and movement through the fracture site. We talked about these little clamps. So you may just have a little thermoplastic or a little bit of casting material wrapping around either the ulnar side or the radial side of the hand, leaves the hand free for function, leaves it free to make sure that those MCP joints don't get too stiff, but it just means if it's knocked or bumped, you don't get the same level of pain. You can use a buddy strap. So you can either do it with Velcro, which we'll talk about, we'll see a picture of a bit later, or these are thermoplastic. So you make two little thermoplastic rings, stick them together, and then as you come down, they're stronger than Velcro would be or tape would be. And that's really good for managing any rotation or just making sure that the finger is well protected in function in that first 2 to 3 weeks. So you can think about tape, Velcro, or thermoplastic buddy. Something like this, we're looking really now at exercises, so we can move this, it's stable, lots of risk of scarring and tethering, move them early. So again, if you can get these patients from your doctors by 2 or 3 days post-operation, ideally they rest for the first 3 days and we move them then when the swelling has gone down a bit and the pain has settled a little bit. There's very little evidence. I put this in just because, we want to look at evidence out there. Not much recently, but there is some evidence to say that moving early is better for function, better for return to work. It doesn't deform the fracture. It doesn't break the fracture down. Passive exercises are recommended from 4 weeks onwards. If the joints are very stiff earlier than that, you can start a little bit of controlled passive movement or even joint mobilizations, so long as you as a therapist can protect the fracture. So don't wait always for passive movement until 4 to 6 weeks if you're really struggling with your patient. Think about your initial exercises. So as I say, ideally, we want to move everybody within that first 3 to 5 days, if we can get them within that time. If they're in a splint, move them within, but making sure that their flexion brings them away from the splint. So they're always trying to get a bit further, a bit further, a bit further. They're protected. The more flexed they are, the more it stabilizes the fracture. It's extension of the MCP joints that puts it more at risk as the intrinsic muscles stretch out and produce more force. We normally reckon the patient should move within 3 to 4 out of 10 pain, so that's a reasonable discomfort for them to move. Think about tendon gliding. Think about, we talked earlier about somebody with a degree of rotational angulation. If you have buddy strapping, as they come down into a flexed position, the good finger will drag the other finger into a better position. If they come at the same time, the ring finger pushes the little finger into its normal alignment. And over those weeks while they're in the splint and in the buddy, you can help to relocate that a little bit and prevent there being a bad rotation, as we saw on that photograph much earlier today. So anyone with pain on movement or any degree of rotational angulation, put them into a buddy strap straight away and let them move within that buddy strapping. Once they've got through that initial protection phase, so the first of 2 to 3 weeks, we want to develop the exercises that they're doing. And again, I've just put lots of ideas. We don't have time to go through everything today, but just to think about intrinsic muscle strengthening. They're always weaker from being splinted, from being part of the injury. Think about ab and adduction. It's also good for edema if they've still got some chronic edema. Thinking about bringing them into an intrinsic plus, but also into an intrinsic minus. So the movement between the two intrinsics is really good. Muscle strengthening, think about isolating. So think about doing an EDC isolated with MCP joint hyperextension. Think about doing a little finger on its own or an index finger on its own. So you're getting all of those extensors to glide. Add resistance. So from 3 or 4 weeks, when your palpation is no longer painful of the fracture site, use TheraBand, use resistance, use putty, use sponges, use anything that gets them working a little bit harder. If you need passive movement, think about 4 to 6 weeks, think about joint mobs, and think about splinting. And we're going to look a little bit at 1 or 2 of those ideas as we go through. Obviously, in many cases, we're dealing with scar, edema, pain, and patients not knowing what's going on. So post-operatively deal with scars intensively. So massage, vibration, silicone gels, anything that just helps to break that scar down. Compression, as we know, is very good for swelling and edema. Kinesio taping or any sort of elastic taping on the dorsal surface of the hand will help to move particularly early swelling. So kinesio taping, I think, is particularly good if you've got access to it in the first 1 to 2 weeks. And then compression becomes a much better way of managing edema after the first few weeks. But these are the things you want to deal with early. So intensively manage those. And that will immediately help the range of motion and reduce the pain. Lots of activity rehab. As I say, they heal quickly. So if you've got very stiff hands, problems with getting MCP joint flexion, you want to be thinking about, using activity rehab either in your department. So thinking about how do you get those MCP joints to come down into a more flexed position with games, sports, but obviously a lot of just what do people do at home? What are their normal things they do at home? If they work in construction, if they're gardeners, if they have a farm, if they, anything that involves tools, handles, small things, things where they're using pinch grips as well as larger grips, that's better therapy than almost anything else that we can do. And think about desensitization. So think about, often they're a little bit sensitive to touch around the fracture site, particularly with a scar. So thinking about bringing in textures, either just, boxes of textures. We often, within the textures, put objects so that they're doing their movement to try and pick up and find the objects at the same time as you're gaining MCP joint flexion. If they're just compensating and using their IP joints all the time, you can put a little splint to block the PIP, and then they have to go from an IP type pinch to an MCP joint type pinch. So you can force them to have to use their MCP joints rather than what is the easy way of just tucking the IP joints into a flex position and cheating with the joints that work really well. So as much activity rehab after that first 3 to 4 weeks for most metacarpal fractures. Resistance, adding a little bit of gripping, adding a little bit of force starts to strengthen the fracture from about 4 or 5 weeks onwards. And we need the bone to get stronger. And it's stimulated to strengthen if you do a little bit of loading in those middle phases, sort of 4, 5, 6 weeks on. So this is the point we really want activity to be working through. So, that's the first sort of few weeks, but we know that quite often either we're only seeing metacarpal fractures around 4 weeks or 6 weeks, or they just get quite stiff. So you may have a patient, and commonly with surgery, with a lag, so struggling to get the extensors to glide, limiting flexion, so that problem of just getting that MCP joint to flex down, and often, particularly for the little finger, just leaving it out of function, so just doing everything with the rest of the hand. And this is a common situation, I think, at sort of 4 to 5 weeks, unless they've done really well with their rehabilitation in the early stages. So just thinking about how do we manage those patients with those problems. So some thoughts around grading. One of the really important things is just to think about your splinting. So don't leave them stuck in one splint for as long as the 4-week period. Now, you may not see your patients very often if they live a long way away. You may not get to see them very often. But if you can cut the splint down from about 3 weeks onwards so that you can end up with this sort of clamp, but leaving more finger movement, more wrist movement as soon as you can, and the bone is starting to heal well. If you've been able to sit your patient in MCP joint flexion, or they've had a cast with MCP joint flexion, they'll have much less trouble coming down into a good position. If they've got a lot of scarring, they're struggling just with that tension on the dorsal surface. So manage the pain, manage the edema, and move them early if you can. I think this is a stage where you want to do a lot of active movement. We know tendon tethering requires the muscles to work hard to pull the tendons against the scarring. So, work them, as we said, with isolated EDC, so isolating just extensor digitorum communis on its own, working extensor digiti minimi, which works with little finger extension. So you're gliding that separately. Work your abductor digiti minimi, FDP, so just working your flexor digitorum profundus, and your FDS with a flat fist. So think about all those muscles that are near or around the fracture, get them gliding and isolate them early, again around 4 or 5 weeks, and start adding a bit of resistance, a little bit of elastic, a little bit of resistance from the other hand, so that the muscle is working a little bit harder. Do a bit more isometric, so that you make the muscle work harder, but without the range of motion. So doing it in a more static position with just the muscle working. And then think about passive. Think about passive yourself. Think about using elastic or tape to pull them down. You can use an elastic band which just wraps around the finger, and you pull the elastic onto a wrap on the wrist, and that'll drag the MCP down. They can exercise against it, but it'll pull them back into line. So something as simple as just a little elastic band wrap onto a wristband will enable them just to get a bit more of that MCP joint flexion. And as I say, add light function. So as soon as you're happy there's clinical union of the fracture, get them doing light activities. So they're using the little finger. If you need to, buddy the little and ring, so the ring finger will drag the little finger along with it and stop it being left out when they're doing things. And then just grade loading, grade grip, grade impact. And just, thinking about loading, the first 3 to 4 weeks is more about protection, exercises, some early strengthening and some resisted tendon glide, so long as it's pain-free. 3 to 6 weeks, assess your clinical union. So do those tests just to see a bit more activity, a bit more loading, but avoid anything that's an impact or something that's a really strong, sustained gripping. Splint may be at times out and about, so that it's not knocked and bumped. And then really between 5 to 12 weeks, they're just going back to everything. Most of the patients you see, we won't see beyond 5 or 6 weeks because they're already doing really nicely. But they should be loading, using the hand, beginning to get back to sport within that 5, 6, 7 weeks from injury, unless there's a problem with their healing. So it's just to give a bit of a feel for how you can educate your patients to load. And then just to finish off, a few thoughts around first metacarpals. The thumbs are always more complicated, we know, but anything that is a shaft, a head, or a neck, all the principles we've talked about apply. Splint them, move them early. Think about this one, a stable, plated, move early. We're now dealing with different tendons, extensor pollicis brevis, extensor pollicis longus, first web space tightening. So think about what could go wrong anatomically and how do you manage them. Think about little splints just protecting the metacarpal. Put them on for loading, put them on if they're stable, only wear the splint out and about. If the fracture is less stable, have them on a bit more to protect the fracture. So very similar to what we've already discussed. The ones that are more complicated are those Bennett's or Rolandos. So the ones that have, complex base, either a Bennett's, which is a single fragment, or a Rolando, which is a double. But in both cases, abductor pollicis longus is the tendon that is pulling them out of place. So we need to include the wrist. It's always for those base fractures, and it might be a cast, may not be a splint at all, but they do need their wrist included for 3 to 4 weeks. Otherwise, that abductor pollicis longus will pull out the fracture and deform the fragments. Even if it's wired, you need to protect it for a while, but leave the IP joint free, fingers free, function. So let them pinch and use the hand so you're adding a little bit of compression through the fracture site. And then to progress them, just as we've talked about, they may need a little step down. I've just put an idea of a splint just to give a little bit of protection, but allowing good flexion. Think about working on the first dorsal interosseous. Think about working on the web space. You may need a little splint just at night to stretch them out if that first web is getting a little bit tight. Watch for MCP joint hyperextension if they're a bit stiff. So you don't want that. You can see my thumb going into that hyperextension. You don't want that. You want the first metacarpal to swing out into abduction and extension. So just watch for that in case. And then finally, just rehabilitation. So again, for the thumb, a few different ideas. Really good to play with different balls. So, put numbers on ping pong balls, or we just make balls out of our splinting material, scraps, and then they have to work. They have to go from number 1 to number 2 to number 3. And because they're focusing on the numbers, they just get on and do the activity for a period of time. Things like kids' chopsticks, tweezers, things that add a little bit of resistance, gets really good work at the CMC joint and MCP joint of the thumb. So thinking about stability with the thenar muscles and mobility at the IP and the CMC joints. So just working slightly different muscles. And I put this in, came from one of the British hand therapy journals in 2011, and it's really a summary of most of what I've discussed, is just a way of thinking around, if it's a base, a shaft, a neck, head, etc., what ideas, what sort of clinical reasoning can you use? How do you think about how to manage? But really, the most important things are movement early, splint for protection, don't immobilize them for long, and grade them quite quickly. That is done with 5 minutes for some questions.
Brilliant. Thank you very much, Sarah. We very much appreciate you communicating that so clearly and making your reasoning so clear to us. and teaching us a lot of extras as you went along. So thank you so much. It looks like we only have one question this evening. We might gather a few more as we address this one. But Jenna, thank you for your presentation. To confirm, is there anything that can be done for patients who present with that dorsal bump?
No. I think the bottom line, it's really, if they're already healed, so most of those metacarpal fractures will be healed within 3 to 4 weeks. So if they're already healed by that stage, therapy can't change it. It's really something they need. Oh, I think I've frozen, sorry. It's really something they need to live with unless they want to go on for surgery. It's very infrequently a functional issue. It's much more of a cosmetic issue. In the very early stages, if you can splint them, so if they've got that bump when you first see them and you can manipulate, or someone else or a doctor or someone can manipulate, you can make a splint with pressure at the head, pressure at the base, and pressure just at the palm or the other way around. So it's probably for dorsal bump, just add that little bit of pressure. So instead of just doing a normal wrap, if you put a little pressure where the dorsal apex is and then push up on the ends, you may help to control it slightly. But mostly educate your patient that it looks a little bit different, but it's not a functional issue. Yeah.
Fantastic. Thank you so much, Sarah, for just really succinctly running us through not a recipe, but really some key principles and key things to factor into our reasoning. So thank you for that. Just before we leave, I'm just going to share a last few thoughts. So as I mentioned, you will receive a link to the Zoom recording by the end of this week. And then in time, the webinar will be made available on YouTube along with all our past webinars. And thank you, Sarah, for being willing to have it as an open access resource. Then our next webinar on the 4th of August is Saving the Central Slip, Hand Therapy to Prevent Boutonniere Deformity. And Mika Bailey and Ingrid Huissel will be presenting that for us. Then to keep up to date on our webinars, please follow us on social media, or you can scan this QR code to join our mailing list so that you get regular updates on webinars and other activities. But we are now at 8:30. Thank you everybody for joining us. Sarah, thank you for joining us from the UK, and have a good evening, everybody.
Thanks very much. Bye-bye.